Reducing readmissions is critical. How to do it, there's volumes that could be talked about on that. I'd like to introduce you to Kumar Dharmarajan, MD, and Susan Bell, also MD, and we're talking about two different things. First off, reducing readmission in the elderly, what can national Medicare data teach us? And then we're going to look at the Vanderbilt experience in specific. First off, you've done a lot of analysis using CMS data for the most part. What have you specifically learned? I mean, where are you now in your thought process regarding all of this based on the data?
So we've learned, looking at the national data, that patients are vulnerable to readmission from a broad spectrum of conditions. So if a patient comes in with heart failure, initially, they're not being readmitted just with recurrent heart failure. They're being readmitted with a broad spectrum of conditions. The same with myocardial infarction. In fact, we've shown that for patients rehospitalized after a heart attack, only 1 in 10 are coming back in with a second heart attack. That means 9 out of 10 patients are coming back to the hospital with a different condition. We've also found that patients are coming in throughout the entire month after hospitalization, not just the first week, not the 4th week. They're at high risk for readmission for that entire month after hospital discharge. And the best hospitals in the United States, perhaps surprisingly, haven't reduced readmissions by lowering readmissions from specific conditions. For example, recurrent heart failure or a second heart attack. The best hospitals have been excelling at lowering readmissions across diagnostic categories and for the entire month after hospitalization.
So should you get dinged for a hospital readmit after heart failure if they're not coming back for heart failure?
I think it's important that we think broadly about patients. Patients are not just a diagnosis. Patients are human beings with complexities, multiple comorbid conditions. And if they're sick, we've shown that patients, when they're initially sick with heart failure or myocardial infarction heart attacks, they can be vulnerable to decompensating and deterioration from a broad range of conditions. And so if we want to have the most patient-centered medical system, and that's what we're here for, to improve outcomes for patients, we need to think broadly about the conditions that are bringing them back into the hospital. And that's not just their initial reason for hospitalization. So it is important that we think broadly about patients.
Before we get to the Vanderbilt experience, one of the questions that you got in the session here at the CV Summit was from an audience member saying, you know, not to be a nihilist about it, but is there anything that you can really do? Are some of these people just simply, there's nothing that we can do and let's forget about all of this nonsense?
No, I actually think there is still room to move on and reducing repeat hospitalizations for older adults coming in with cardiovascular conditions. How much we can reduce them is not known, but from our experience at Vanderbilt, which I'll speak about later, is that we have shown from our sort of assessment of patients, some of these hospitalizations are preventable, and poor communication and poor follow-through of care may be some of the keys to that. The other part is that as this is becoming a penalty for hospitals for higher rates of readmissions, everybody across the nation is going to be doing processes of care to reduce their repeat hospitalizations. There is room to move, and that as other hospitals reduce their readmission rates, we too have to reduce them at each different hospital facility. But I do think there is room to move on these.
I mean, you talked about a patient that had a specific candy bowl that was awfully interesting. Can you tell that story?
Sure. I think for many patients, especially older patients, they're put on a lot of medicines. Susan earlier spoke about her experience at Vanderbilt. Often a patient may be on 24 different medications multiple times a day. Right. And so one of my mentors was making home visits for patients, trying to evaluate why they were at high risk for readmission, how they were taking their medicines. And the patient essentially told him that it was hard for her to manage her medicine. So she just poured them all into a big candy bowl. And every day she would just reach into the bowl and take whatever medicines ended up in her hand. And she found that was easier than figuring out exactly what medicine she had to take at what time in the day and fill up her pill box. It was just easier to take a handful.
So is the answer there to review meds?
I think it's critical. I think the answer is manyfold. So it is important to review meds. I think especially in older patients who are at high risk for complications from side effects from medicines, Medicines may interact with each other. They may interact with another condition the patient has. I think it's very important for us to reduce unnecessary medicines, and older patients take unnecessary medicines in spades. Medicines that may be providing them little benefit and high risk for complications. I think that's a key point for anyone taking care of older patients, and that's to minimize the medication burden.
Let's talk about Vanderbilt for a moment. What did you present? What have you learned there?
So I presented data today from our Vanderbilt CMS demonstrations project, an innovation project where we're looking at specifically trying to reduce readmissions for individuals that are transferred to post-acute care facilities. So these are skilled nursing facilities. They have the highest readmission rates of individuals who leave our hospital, and they are the sickest of our patients. And they come back to the hospital with either complications of disease processes that were present in the hospital or ongoing geriatric conditions that were just not addressed within the hospital. They also, when they're at the facilities, are unable to participate in the rehabilitation care that we've sent them to do because they're still so very unwell from their medical conditions and things like that have been complications like urinary tract infections from unnecessary catheter placements, adverse events from medications, and so that what we're spending our money on sending people to rehabilitation may be not being provided to the patient in the correct way because they're not able to participate in that.
So what are you doing differently now than you did, say, a year or two ago?
So what we did was we looked at what we were doing at that moment. So we looked at what our best practice care was, and we found lots of gaps in our actual best practice care. And a lot of them fell into the domains of communication of ongoing medical problems. Most people, when they leave the hospital, are not back to what they were when they were in their sort of pre-morbid condition. They still have a long way to go to get better. And a lot of these management things weren't being communicated to facilities to follow through with. So things like follow-up laboratory tests, medication management, and other geriatric syndromes such as individuals losing weight or having problems with incontinence or confusion wasn't being conveyed to the facilities. We also had a lot of problems in this with medications, medication lists that were incorrect that would be going to the facilities, so the individuals weren't receiving the medications as prescribed to the physicians, by the physicians. And this is just through paperwork and large amounts of paperwork that are transferred across. So what we have done is we've really gone back to the basics and really gone back to communicating accurate information to the facilities so that they can receive a smaller amount of communication materials, but all of it is accurate and is beneficial to the patient. And we've seen our hospital readmission rates decline. There is a fluctuation in them, but we have 3 years to be able to demonstrate that this is going to improve the care of our older adults. Right now, I'm very optimistic. And I think 30-day readmission is a quality indicator that a lot of us feel slightly uncomfortable about because 30-day readmission may be sort of a financial sort of goal for people, but what we're trying to do with all of these projects is improve quality of care, and that's always the right thing to do. And I actually think that long-term outcomes from disease processes and also functional decline and people being placed long-term in nursing facilities are going to be much better markers of actually the quality of the care that we're giving to patients when we transfer them and discharge them from the hospital.
In CSWN, we had a cover story. Is our 30-day readmission a really lousy quality metric? Because there certainly are arguments. In ACS, it works just fine, but is it a lousy quality metric in your opinion?
I think we need to, when we think about older patients, think about universal health outcomes. So those are outcomes that are not just disease-specific, such as your level of blood glucose control or your degree of blood pressure, your systolic blood pressure. We need to think about outcomes that are important to patients. So those can include things like survival. It could include things like their quality of life. It include things like their symptoms and their burden of symptoms. Rehospitalization for me falls within those categories. And the reason is being rehospitalized is a traumatic event for a patient. You've just been in the hospital, you've been discharged, and you end up back in the hospital. And the reason why it's particularly deleterious to older patients is when we put them in the hospital, they're immobile in bed, they lose muscle mass, they get a urinary catheter if they have heart failure, so they can get infections, they can have falls, they can get confused, they can be in pain, They can get malnourished because we often make them put them on temporary restrictions with their food as they wait for procedures. And all of those things for older patients can lead to harm. And so I think readmission is an important metric. And what readmission gets us to do is to think about integrating patient care across the spectrum of locations. So formally, hospitals were just concerned, oftentimes, because the financial incentives were such, for the care they delivered in the hospital. And if the patient was discharged and rehospitalized, again, the hospital could, again, bill for their services. I'm not saying the hospitals were intentionally causing harms for patients, but they weren't forced to think about the care spectrum. And the hospitals are really the most powerful node in our healthcare system. And if we need an organizing force to help integrate care for patients across environments, the hospital, post-acute care settings like nursing homes, the community where they live, whether it's in their home or an assisted living facility, we need to think about creating policy that can help do that. And I think the important thing with the readmission metrics is that they're really getting us to think about long-term outcomes for patients. Right now it's just 30 days, but with accountable care organizations, these bundling payment demonstration initiatives that CMS and other organizations are putting forward, they're really fundamentally about ensuring good outcomes for patients over periods of time. Of course, that could save money, but it can also improve care for patients and prevent these really big events once they leave the hospital.
Based on questions you both got, I've got one final question for both of you. In your case, someone was asking about the fact that in your experience, you've got a situation where you have people who have been leading into a nursing home, for example. What are they learning from the data that you are supplying?
So from the information we're providing to them, we're providing them the key components that are critical to this individual's continued care. So we absolutely highlight the things that are very important for that individual. So for each older adult, they may be a different spectrum across the patients because they're all heterogeneic. And what we try to do is highlight the things that need to be followed through from. So if someone has been delirious in the hospital, we like to try to convey that information to the facility so that when the physician is called at 2 a.m, this patient is confused and walking around the facility, they don't do the first thing that usually comes to mind, call 911 and send them back to the hospital. They know, I knew that patient was delirious in the hospital. Delirium has a spectrum of waxing and waning. We just need to sit this one out. Let's get them in a safe environment. Let's do behavioral measures. And so we're conveying that kind of information. We're conveying information like this patient has had weight loss for the last 3 months. They're now at a BMI that is underweight BMI. We really need to address nutrition because we can't improve this person's functional status until we stop the losing weight in this individual. So there are a lot of things like this, accurate medication lists, accurate laboratory tests and results of these that are in the hospital and things that they need to follow through with. And then information that they need to give their caregivers and family, because actually one of the highest readmission rates is actually when the patient leaves the skilled nursing facility and goes home. That is actually a vortex of problems that occur because they've been transferred to a facility where things are being taken care of them, and these are our very sickest patients, and then they get sent home without the coordinated care that is normally going on when you get discharged from a hospital. So we're conveying information to the physician in the facility that they can then give to the caregiver as they go home as well.
And someone asked you about readmission. Is early release, is that a problem? Is that one of the factors that's driving early readmission?
So it's hard to know. So when we looked across all Medicare patients with traditional Medicare insurance, patients with the highest readmission rates tended to be those who had the longest length of stay. And that's not surprising because the patients who are in the hospital for the longest length of time tend to be the sickest patients, and you'd expect them to be readmitted at a higher rate. When we looked at the hospital level, hospitals with the highest readmission rates also tended to be the hospitals that tended to have the highest average length of stay. So what that means, it's not clear. Is it that the hospitals with the highest length of stay are the least efficient and the least well coordinated, and so their higher readmission rate is a function of internal processes that are reflected in that length of stay? We don't know the answer to that question. I think on a case-by-case basis, as a provider working in a hospital, you can think of cases where a patient did come back to the hospital and you wonder, did that patient go home too soon? So I think on a case-by-case basis, That could be an issue, certainly, but I don't think people have shown definitively that early discharge is systematically responsible for a large fraction of readmissions.
So again, we're at the Cardiovascular Summit here in Las Vegas for 2014. Please see our coverage in CSWN as well as online. For CardioSource World News, I'm Executive Editor Rick McGuire.